All right. Well, good afternoon, everyone. It's just a minute behind after 12 on the East Coast. I'm just glad that we're here again today. I know that we've had like a kind of a different set of moderators and speakers and all that. So we just tried to bring it back to the originals, speaking on healthcare and patient-centeredness. And I'll just go ahead and I don't even know if the two of them need introduction. They've been one created NMQF and one has essentially been the anchor for our Friday discussion since we started back in 2020, in April of 2020. So future Dr. Keeys and Dr. Puckrein will lead today's discussion, and I will just turn it over to them.
As usual, Brandon Garrett, thank you so much for your gracious introduction. Really excited to be here back with the NMQF fam. I know I've said it before on previous webinars, but this is my favorite time of the day on Fridays in terms of being able to geek out, but then also very much be talking about things that matter, not just for now, but we're talking about pushing the needle with respect to 21st century medicine. And who better to do that than with Dr. Puckrein? And so today, Dr. Puckrein, we're talking patient-centeredness, right?
We are talking patient-centeredness, absolutely.
Absolutely. So we'll go ahead and jump right in. Really excited for participants who are on the webinar. If you have questions that you want for me to pose to Dr. Puckrein and reel it into our conversations, then please drop your questions in the Q&A box below. But otherwise, keep comments coming on the side. Make sure you're chatting it up with others on the call. Put your chats on the side and your comments, or excuse me, your questions below. Comments on the side, questions below. All right. So let's just jump right on into it. Dr. Puckrein, what exactly is patient-centeredness? What do you mean by that?
Well, NMQF, we've been thinking about these issues about health equity and actually, when we got started, it used to be called health disparities.
Health disparities, right?
Yeah. Well, now we're talking health equities, we've kind of come to that moment where I think the opportunity is really here to begin what I would describe as the reimagining of our healthcare system. For those who don't know, my doctor's in history, so I'm always starting things with a historical lens. And the historical lens is really that inequities have been a part of the American system forever. Healthcare being only one variety of it, but when you look across the landscape, part of what America was is that it extracted wealth from African Americans and other people, and in that extraction, it gave them less, and that's what the inequities are, and healthcare being one of those. So the health system that's evolved now, I would describe it as focused on financial risk. When you think about it for 2 seconds, what you see is a system that when you enter the system, the first thing they want to see is your insurance card, right? If you don't have that insurance card, you don't get to go any place within the system. But even with that insurance card, it tells the doctor what you can have, how long you can have it, who can give it to you, how much he can give it to you, what is your copay, and also the system is quite prepared to deny you access to care even when you need it, even if it's life-altering medicine that could actually save your life. And if you really want to try to get to equity, then we have to talk about the healthcare financing system. We have to talk about what is our priority when it comes to taking care of our population. And the argument I would make is that healthcare is actually, in its own right, patient-centric. And what I mean by that is every patient who comes into the healthcare system expects the system to lower their risk. I don't know of anybody who goes into the healthcare system, at least sane, that has the expectation that the system is going to elevate their risk, that the system is going to deny them access to appropriate care, give them less than appropriate care, etc. But that's what happens. The healthcare system, if you push really hard, people don't like to talk about it, but it has a rationing model. It says that healthcare is a scarce commodity. We can't give it to everybody. And so we have to ration. And part of the way it rations is through dollars, ability to pay. You can have as much health care as you can afford to buy. And so in that model, underserved populations, minority populations, poor people, rural populations, they get less than adequate care. And so, I mean, if we're really going to have a conversation about equity, then we have to talk about making sure that everybody who comes through the door gets the care that they need, and that rather than the system be focused on financial risk, it's focused on patient risk, that the value proposition, the value in the system is taking care of people's health. I think that's transformative. I think if the business model is really around taking care of patients, and that's what the system values, and that's what it pays for, the minute you do that, I think issues about race and other things go away, because guess what? If you're going to make a living taking care of patients, you don't actually care what they look like, right? I mean, that's the point of the matter, is that if the patient outcome is really what drives the system. And also the reason why that's important is because we're entering into, or maybe we're already in, a medical revolution. We are developing therapies that earlier generations could not even imagine. You take those liquid biopsies for cancer. We're able to diagnose 50 cancers at one time before the patient is symptomatic. I was talking to a clinician at the Mayo Clinic a couple of weeks ago, and she was telling me that for multiple myeloma, they can predict who's going to have multiple myeloma 15 years before they're symptomatic. Think about that, 15 years before they're symptomatic. Is our healthcare system prepared to treat someone who is asymptomatic but is likely to get multiple myeloma 15 years from? No, it's not. It's not designed to do that. And then screening's one side, but therapy's on the other side. We are now producing medicines at the genomic level, right? How are you going to pay for that? In sickle cell, for example, sickle cell is probably one of the first diseases that are really going to have a cure, or at least pretty close to a cure. So there are roughly in this country about 100,000 people with sickle cell. How about we pay $1 million a cure? Is our society ready to do that? Right? And so I could go down the list of diseases and ability to provide care. Right now there's tremendous science going on around obesity, right? It's against the law for us to pay Medicaid, Medicare, to pay for obesity medications, right? I mean, there's laws that prohibit that, even though obesity is a gateway to diabetes, to cardiovascular disease. And so you get the point that if we're going to be truly about the patient, if we're going to be truly about dealing with equity, then somehow we're going to have to reimagine our healthcare financing system. It doesn't have the ability to take us where we want to go right now. In the best case, what it will do, or at least those who have resources will think that I can buy my care. I don't have to worry about myself and my family. I got the capacity. It's my neighbors that got to have their own lookout, right? But that's a narrow thought, in the sense that we can't build a healthcare system for the 1%. At the end of the day, we have to generalize those costs across the system if we're truly going to innovate. And so I would argue that if we are really going to explore the frontier of survivability, how long we each can survive, and or how long our communities can survive, then we're at that place where we really have to put some deep thought into how do we finance this? How do we build? Everybody talks about equity. Nobody talks about how do you pay for that? And they get off into the social determinants of health and all those things because they don't want to take on that hard question about how does the system get financed. And so that's, at NMQF, that's really where we are now. We are starting to say two things. One is, all right, we have to reimagine this. In the same way that people talk about reimagining policing in America because of the way policing has disproportionately impacted populations, that we need to put new ideas in place. The same thing is true in healthcare. We have to reimagine it, and it means we got to get all the right folks around the table and have an honest conversation. But I don't think we can start from the place where we want to say that healthcare has to be rationed, that some people can't have because we don't want to invest in them. Because the minute you do that, you will have inequities. I mean, it's kind of part of the deal.
Dr. Puckrein, as always, you've already given us so much to chew on. I always take notes when you speak, even if it's on a napkin at dinner time. I'm going to, remember your words. A couple of things that I wrote down for myself to bring up. Talk to us, Dr. Puckrein, about what you mean by being potentially at a point where medicine is transformational, is potentially in a revolutionary time, and what does that mean given where we are politically, and how do we then reorient providers to think about medicine in this quote unquote non-traditional fashion?
Right. Well, on the policy side, our members need some help in envisioning what that future looks like. They're governing really without a clear sense, at least some of them. Some of them are looking backwards and they're trying to hold on to
That's
something
right.
that ain't going to happen, right?
That's right.
That's a foreign country back there. We ain't going back to that country. But the real challenge is to have that vision about what that future looks like. What are we trying to get to? Where are we trying to go? And I think what I'm saying is the place that we're trying to go is we want to be able to provide lower risk for every patient who comes through the door. When they come in, we want to make sure we keep them out of the hospital. We want to make sure we keep them out of the emergency room. We want to keep them from disabilities. We want to help them with their functionality. And certainly we want to keep them from dying. And those are all numbers, right? Those are all things that we can quantify. And that quantification tells us how the system is performing, right? And so that's the point. It's a numbers game. And so you can look across your population and see. So when we talk about health disparities, what we're essentially saying is year after year after year, we're producing numbers that we know are inadequate for a particular cohort of patients. That we could do better if we wanted to, but we don't want to do better. We're kind of satisfied with that status quo, and that's going on for generations actually. So I think what I'm saying to you is that purpose. It's about purpose at the end of the day.
It's about purpose. It's about being on purpose.
Absolutely. You can't get there if you don't know where you're going, right? And I look at and have had the good fortune to sit around some of the folks who are building and presenting all of these new technologies and capabilities is stunning. I mean, it's just unimaginable for early generations. If you think, CRISPR is about gene editing, that we can go in to the book of life and rewrite the code. Right? I mean, that's what we're talking about essentially, right? And so that creates enormous opportunities, but we can't take advantage of them collectively in a healthcare system that, at least the financing portion of it, I think that's probably the most broken piece of it, that is stuck on rationing, is stuck on my job is to limit access to, and let's be precise, right? So if you look at CBO scoring, right, for healthcare, think about that for a second. So before the federal government is going to invest in healthcare, it sends it up to the Congressional Budget Office to get a score.
Yep.
And the score is not, well, we're going to improve patient outcomes, we're going to keep them out of the hospital, we're going to keep them out of the... That's not the score. The score is, do we want to pay that much for it? That's our value. That's what we want to hold on to. And so it limits the federal government because it's always looking for a pay for. It's always looking for how do I invest in the health of the American public? And I'm saying that that's not. CBO scoring was created for a different reason. It wasn't created for health care. It came out of a fight that Nixon was having with Congress because Nixon wanted to do some line item budget extractions, right? And Congress created its own scoring device, and CBO, Congressional Budget Office, became that. But I don't think anybody contemplated, it didn't matter at the moment because there wasn't much science coming down the pike back then anyway. But I don't think that's a good place for us to be. So that's just for one example.
So that was quite a vivid example, Dr. Puckrein. Let's stay with the precision talk, and I don't mean in this case precision medicine. At each level of care, talk to us about, in terms of reimagining what care would look like. What does that look like at each point, right? What does that look like before a patient comes into a medical establishment? What does that look like for the providers that they're seeing? What does that look like for the decisions that are being made that drive how the providers are preparing medicine? All of that.
So let me take you all the way out to the frontier.
Take me on out. I have my walking stick. Let's go
out there and try to understand who we are and where we are. Mm-hmm. And my staff, they know this because I beat them over the head with it all the time, right? One of the most interesting things for me that's come out recently is the James Webb telescope. If you think about that, so that telescope.
Yeah, they just announced that. Like last week. Mm-hmm.
Yeah, that telescope.
Incredible pictures.
Yes, it's looking. It's like a time machine. It looks back 13 billion years. Right?
It's incredible.
It's incredible, right? But what is that telescope telling us, and what are we trying to do with it? As far as we know, Earth is the only life in our solar system. There's no life on Mars, there's no life on the moon, Jupiter, Saturn, right? You get out to the Milky Way, and as far as we know, there's no intelligent life out there. There ain't one signal, one beep of a horn, right? The James Webb telescope is intended to see if there like 100 trillion galaxies out there, right? And it's trying to find out, is there anybody out there at all? Because right now, ain't no signal that there's anything going on. And here's my point for saying that. We are exceptional. I mean, that's the message that we're not picking up, right? Our life is exceptional. The code, that DNA code that we talk about, that came out of an evolutionary process on this planet that took millions of years. right? So you're taking this very, very rare, exceptional thing called human life, right? And you bring it into the healthcare system and you devalue it because you think that money's more important. And my sense of it, this is my particular prejudice, is that our job is really to conserve that life because it is so exceptional and so rare that patient-centeredness, that's what it's about. So when I'm talking about patient-centeredness, I'm talking about bringing together all that person that you see down in the gutter that we walk over that begs us for money, and you don't want to look at them and say go get a job or whatever the heck you want to say to them. That person is exceptional. That person in the universe of things is incredibly rare, right? But we don't value it that sort of way. So anyway, the point is, as we start to reimagine our healthcare system, we have to reimagine it from that perspective, that we're taking care of something so very, very rare, so incredibly precious, that we need to treat it that way. And what we're trying to do is find the best ways to conserve it. I think that's our future. I think that's where we're headed. For a whole bunch of reasons, climate change being one of the things that is going to pressure us in that direction. But that's the reality of the human existence. I think that's the point.
I'm going to let that moment breathe for a second and do something I never do on this one on here. But there's a book I want to show on screen. It's literally not even 2 feet from me. Give me 2 seconds. Yeah, everyone else just take in what Dr. Puckrein just said. I'll be right back. Okay, I'm back. Dr. Puckrein, there is a book that I'm reading that everything that just came out of your mouth, it reminds me of the thoughts that I've been having after reading this book. And this is not an endorsement of this book via my organization or Dr. Puckrein's. This is just me, nerding out with Dr. Puckrein. Please read this book, Life 3.0. And I've been dog-earing it and such like that. Dr. Puckrein, when you're talking about understanding where we're going by being, by taking the time and being on purpose about looking where we've been, you're talking about looking deep, you're talking about still being in a space of astonishment. I think we've reached a point, and maybe our species are fatigued in some ways about how exceptional we are, because we come across the same people day in, day out, same issues day in, day out. It could be a survival mechanism trying to avoid the fact that this is heavy talk. This is heavy talk, right? But when we sit still and think about exactly what you're saying, which is we are exceptional, we are life-giving, and there's so much life to still preserve, it takes time to consider that we've not exhausted all possibilities, right? We still have room to be astonished. And I want to be astonished with respect to our healthcare system. I want to be taken aback in the best way, right? I don't want to be taken aback because we're coming up with newer and more dismal numbers around maternal morbidity and mortality, around chronic conditions, around acute conditions that either should no longer be with us in 10 years or they should become chronic, right? I don't want to be completely, just undetermined in terms of my own purpose and course, because our people in power aren't willing to have the conversation about human value, right? So as we're looking back, how do we, in your estimation, remind each other of this purpose? Because that's not the level of conversation that members of Congress are consistently having, unless you're talking about sound bites, right? That's not the level of conversation that you're going to get at a CMMI all the time or at CMS when you're talking Medicare and Medicaid reform. So how do you then insert insert this level of self-awareness and before and after your time, into these conversations.
I think the equity question raised it. I don't think I raised it. I think the equity question raised it. I mean, if you're really serious about equity, I mean, that's really where you can have equity on the surface, and we can put Band-Aids on things, and we can run around and have great meetings, and do a bunch of one-off projects, and
right.
Declare victory and go home, right? But if you're really truly committed to equity, it means that intellectually you have to be committed with it. You have to have an intellectual framework. You have to understand. So why am I doing this? Why is equity even important? Right? What's the purpose here? And I think that's what leads you down the pathway to take an assessment of who you are in your community, and what values you think are important, and what that future to be like. Because when you say equity, what you're saying is we want a healthcare system that every day, in every instance, is trying to provide the best possible care for every patient. Doesn't matter their gender preference, doesn't matter their skin color, doesn't matter their disabilities or their infirmities, whatever it is. And the other thing you come to appreciate as you talk about equity, you realize that it is a collaboration, right? It is a very deep collaboration.
It is a collaboration. Yes.
That is it, because we all have to work together to achieve that. So I don't think it's me. I think it's the question that's been raised, right? If it's a serious question, that leads you into these places. And then I think also, we talk a lot about the technology in healthcare, but the James Webb Telescope and all of those kinds of technologies, they're creating the context, the moment, where, think about it. When Kennedy sent people to the moon, and where we are now in terms of exploring space and talking about putting people on Mars and all that, how are you going to put people on Mars if you can't do healthcare here, right? What happens when you get diabetes on Mars? I don't know.
That's so funny.
Yeah. But that's the reality,
not,
right?
Not to say we don't want to push the margins of exploration, but yes, to your point, to your earlier point, what are our priorities?
Exactly. So it's just the whole equity question causes you to expand your vision, causes you to open up and say, I got to get a broader framework around this, and that's the conversation that has. Now, mind you, there are a lot of people in the equity space. It's just they're just running around.
Well, because it's so sexy now.
Sexy and financially beneficial.
Yes, it is.
That brings a lot of folks as well, which is not a bad thing. But the point is, at the end of the day, if we're really, truly about bringing full equity into our healthcare system, it's a different system. It's not this one.
It is not this one.
And so, I think that's the challenge.
One of the things that you hearken to, Kennedy's words on going to the moon. I'm also thinking about that time frame, because when you're talking financing, you have to talk Medicare and Medicaid. A lot of people don't realize that Medicare and Medicaid came out of the civil rights generation, right? And Medicare was stood up in '65, and Medicaid came soon thereafter that. And thinking about who were our voices, who were pushing for the transformation that you're coming to, of course, you can think about Martin Luther King. I mean, he wasn't using terms like health equity and health disparity, but he was saying health injustice. He was talking about the social determinants in terms of jobs and socioeconomic status and such like that. He was just pushing for systems change anyway. When I think about someone like King, and his cadre, and John Lewis, may he rest in peace. They were looking to pass the baton, right? And that's why they had people in the ranks. That's also what I see in terms of the purpose of these webinars. This is really also a generative conversation, because there'll be somebody who's going to hear this and say, okay, I can think about what I need to do. This is the inspiration that I needed. King was inspired by people who were, to your point about collaboration, who were not within the quote unquote social justice realm on his head. Right. A lot of people don't know this, and I thought about this is me going on a tangent, but I'm going to bring it all back, I promise, and then we're going to open it up to questions. I've been doing a lot of listening to Mahalia Jackson lately, and mostly because I love her voice, beautiful voice, the woman, I mean, incredible. And I do a lot of the listening now with my son, even though he doesn't know the words. He's 7 months. He doesn't know the words, but he immediately sits at attention when he hears her singing. And I was thinking about the role that Mahalia Jackson played in bringing us to a point where now we are thinking about health equity, because had it not been for her shouting out at the march on Washington for jobs and freedom, tell them about the dream, Martin, then none of us would have known or heard the I Have a Dream speech, right? It was about, and my takeaway from that is, when you're pushing systems, when you're pushing for change, you're going to be tired and fatigued. And the response in those moments tends to be the status quo. Let's just keep doing what we've always been doing. It's when you're surrounded by people who are going to not only hold you accountable, but keep you inspired, and they don't always have the same perspective that you do, that you're going to then say, oh, this, what I have to say is valuable, because it's going to speak to the humanness in all of us, and all of us are going to receive this message, and that's going to matter generations after I'm gone. That's going to push the needle. So I really appreciate your comment about collaboration and expansion there, and imagination. And shout out to Mahalia Jackson. You all need to listen.
I appreciate you bringing up King in this context, because let's take a moment to think about the African American experience in this context. Right? So what most people don't realize, it's only about 55 years since African Americans really, if you use 1965, as most people do, as the point where African Americans had generally the vote and the rights to speak freely, and generally speaking, to own property. But prior to that, it was all aspirational, right? It was the aspirations that go back to Phyllis Wheatley and Frederick Douglass, all of them, right? Mm-hmm. They were all, and what they were aspiring to is, when do we get a moment to talk about the community that we want to live in? When do we have the freedom to set up and talk about our contribution to this society? And that's what equity is, right? Mm-hmm. It is now, for the first time, when not only do we bring our voice, we bring our experiences to the conversation. Mm-hmm. And our experiences has been around, we understand what inequities look like. We've lived our whole existence. Think about that, a whole life existence of inequities, of the inability to be free. And so as I look at this equity conversation, that's another piece of the puzzle that you're bringing into the conversation, these voices that have lived the whole limited access to quality health care, their life shortened, living in pain and hospitalization, and all of those things that were unavailable to them, that would have made their life a lot easier and more pleasant. And so it is a gigantic bundle of things, right? This new technology, this historic experiences.
It's galactic.
All of that brings us to the place where we have this conversation now about America is now a multicultural democracy. How do we take care of all of our people? How do we make sure that everyone has access to high quality healthcare. It's a tall order, but I think that's the future, and that's the challenge that we have to take on and begin to define that reality.
So, Dr. Puckrein, I want to weave in some questions from the audience, and I'm also hoping. So, I hear a lot from young physicians, young dentists, young nurses who they are inspired and have a value system similar to what it is that you are describing, right? But then they get into the institution, and particularly our Black and brown aspirational providers, right? And they say, well, I want to push the needle. However, I want to change the system, but I need to pass this test. I need to get into the high-ranking residency program, so I need to close my mouth in order to climb the ranks. Knowing that that's the case for a number of people, how then do we beat out of that? You know, how does that break without it then adding to the pressures on the back end, which, you know, once they reach a certain place, they might feel compelled, or even once they are established, wanting to stay in that established space, because not being a part of an established institution might mean that their recognition as leaders would diminish, or returns on their investment would not be as monetarily gainful. How then do we grapple with that when we're trying to really elevate the transformative equity, patient-centeredness conversation?
This is where I think the patient voice is so incredibly important, right? The status quo is not going to walk away and go away because we say it's time to go, right? It's got deep historic roots. And I think, as I look at it, the group that's most able to play catalyst here are really patient advocacy organizations, because their values are aligned with equity at the end of the day, because they're the ones who are coming into the healthcare system and saying, in most instances, they're looking at a therapeutic area. You know, I want better for kidney or lupus or whatever. But what we need to get them to understand is the opportunity in a single therapeutic area only really comes when we're doing it for everybody. When we're not just thinking about one unique condition, which is not to say they need to walk away from that, but they also have to have that broader vision of of how we need to collaborate in order to get the system to perform well for everyone, and so it takes the pressure off of those inside the system who have to put their lives and their families at risk in order to make the change. Those externally create the permission internally to have the conversation, because they can point to those voices and those partnerships externally that can be of help. And so I'm always pressing for the patient advocacy community to come together and be a voice. There'd be a much better voice on the Hill than coming individually to a member of Congress. You know, the diabetes group comes in, the asthma group comes in, but if they came in together, it would make a much more impression on a member when he sees all of his constituents sitting in front of him or her and saying, so here's the way we think we need to begin having this conversation.
That's it. Well, I think that point is well taken, and I hope that certainly resonated with a good number of you who are present today, and make sure that you spread that word in particular. Let me talk to you about some of the questions the audience has. Dr. Puckrein, what are your thoughts with respect to why some people engage the healthcare system only when they've reached crisis level, critical level? And what are the mechanisms to reorient that behavior?
Boy, that's a really tough one. So I play around with data all the time because we're always trying to help folks make good decisions about their health. And I've come up with this very rough formula. Doesn't apply all the time, but I think it's pretty close. So about 30% of the population, I don't care what you say to them about their health, they're just going to do what they want to do, right? And what ends up happening for them, so there's an objective reality out there, in that world of the universe and galaxies and all that. There are natural laws that govern all that, including us. And so you could decide that I don't want to get vaccinated, I don't want to wear a mask, I don't want to, whatever you've decided you don't want to. The natural world doesn't actually care. And it will punish you if you make the wrong choice. And the wrong choice could be intentionally or not intentionally, but it is going to punish you. And so those populations tend to have lower life expectancies. They have higher risk for hospitalizations and disabilities and all of the things that come with the fact that they're not taking care of themselves. Then you have roughly about another 40% of the population that are minding their health. That they're going to the doctor regularly and they're doing whatever they can to the best of their ability to maintain their health. And then you got another 30% that you can persuade. You could say, and give them good information, and they'll make good choices. When I look at the data, that's roughly what I see just about in every instance. There's going to be that 30% that are just hard to reach for a variety of reasons. But then when you go look at their numbers, what you see is that low life expectancy, hospitalizations. There's a few lucky that get out because the odds are the odds. But that's roughly how the game gets played.
So I'm as you were talking, we all have people in our lives that fit each of those categories, right?
Yep.
And we know what the retort is, or we know what the conversation is going to sound like, right?
Yeah.
All of that, and then when it becomes, and really, COVID has probably been one of the best narratives that speak to, at least qualitatively, that speak to those data, right? Where you still have people who, for whatever reasons, right? And those reasons could be personally motivated and therefore sensible, or they can be politically motivated and therefore not critically thought out, right?
I was looking at some data once, hemoglobin A1Cs, which are used to measure blood sugar levels over time. They're a good indicator of diabetes, the management of diabetes. So looking at hemoglobin A1Cs by race, and African Americans and Hispanics under the age of 65, their hemoglobin A1C levels were always much higher than whites, particularly for diabetes. Until you got to the age of 65, right? And once you got to the age of 65, the hemoglobin A1C levels sort of became almost similar. And we scratched our head for a long time, and then we realized what was happening was it was a survival pool. That those folks who didn't manage their hemoglobin A1Cs,
they died.
Right. And so the ones that did manage their hemoglobin A1Cs,
they leveled off.
That's the point, right? And that was one of those indicators to us that, okay, this is what happens when you. Now it's hard to say to people because people don't like to think about life as odds, but it's about odds.
Very much so. I mean, demographers tell you and remind you of that all the time, right?
Yeah.
Very true. Yeah. You were speaking, I mean, going back to, it's not far-fetched to compare, and I appreciate that you did, the healthcare system and the way that it's moved innovatively to the way we see policing, or even the way that we're navigating new space, literally. So what then is the role that you see in terms of telemedicine, in terms of new innovations with respect to telemedicine more broadly, but telehealth as well?
I'm going to invite everyone to Google looking at the systems that are built to manage herds, cows and chickens.
I'll do that right now.
And what you're going to find is any good farmer has some biometrics that helps him understand the health of his population. And that's where we're headed. We are going to have, when people talk telehealth to me, I'm not just talking about videos and telephones, I'm thinking biometrics. I'm talking about devices that monitor your health patterns all the time, and your doctor or healthcare provider or some algorithm is going to be monitoring those biometric devices. That's where we're going, and there's a lot of new startup companies and others out there who are producing. So, I think we're sort of in the early stages of that conversation, and people think about telehealth as well. I can have a video conversation with my doctor, or I can pick up the phone and talk to my doctor, which is all good. I can have a Zoom call with my doctor, it's all good. But it's much deeper than that. It is, for example, CGMs, continuous blood glucose monitors for people with diabetes, right? They're helping to really manage people with diabetes, with cardiovascular or chronic heart disease, and monitoring body weight. They can anticipate hospitalizations by the amount of fluid that gets stored. Absolutely. I think the whole frontier of telehealth is sitting in front of it. It's Star Trek, right?
Yeah.
It's
it
what
is.
it is.
It is very much so.
That's exactly where we're going, no question.
Mm-hmm. Particularly when we're talking about harder, quote unquote, historically harder to reach communities, right?
Yeah.
One of the attendees is a primary care physician, PCP, and would like to know, given that third of the population who are not either in a position to care for themselves consistently, and that metric being regularly going for appointments and such like that, or are not motivated to, or find the institutions to be untrustworthy, whatever reasons, how do you ensure that equitable care is still provided, or that headway is gained, even if it sounds to me like a push factor. These are push and pull factors, right?
Sure. I think for Gary Puckrein, I would say we have to learn a lot more about them as a cohort, right? I spent some time in London studying, and it was at a time when Americans were buying pet rocks, and so some of my English colleagues would come to me and say, "Why are Americans buying rocks?" Right? And the point is, we sell anything.
Yeah.
We can figure it out, and that's my point about healthcare. That when we become to value the life, even that life that is hard to reach in terms of getting the healthcare message across, and the system really wants to reach that market, right? It'll figure out how to reach that market. It will find doorways into that marketplace, but there's no incentive right now to do that. There's no value proposition in terms of commercial value, if you will, to do that. And so my faith is in the marketplace, that if that becomes a value to understand why that person doesn't get vaccinated, why does that person come to the doctor regularly, why does that person continue to smoke, or whatever the issue is, that's really valuable. There are a whole lot of folks who will set up shop tomorrow, and I would say in a year's time, they will sort that out and they'll find ways to reach them that right now we're not thinking about.
And to your point earlier about the equity process, the equity strategy being collaborative, this is another reason why, beyond providers themselves, social workers and patient advocates in particular, excuse me, are so significant strategy.
The way I always shorthand it is, we want an economy that supports our biology, right? Historically, we've had an economy in which our biology supported the economy. And now what we're looking for is an economy that supports our biology. And in that economy, that very difficult population to reach in terms of health messaging, if there's a business opportunity around that, a third of the population, you're talking 90 million people, right? You're talking about one or two folks, you're talking about a lot of people. That's a big market. Yeah. And so if somebody woke up tomorrow and said, we need to reach that market to get them vaccinated or whatever it is, I think the market's smart enough to figure that out.
I mean, we saw how quickly new innovations were created and how systems coalesced around COVID, and obviously in crisis situations, but at the very least, it showed how, it showed the potential that the market has. And it showed, when the market wants and when drivers of the market want it to, it will drive at all costs to ensure that resources are set up. And not just resources, obviously, in terms of actual care provided, but time and time sitting with patients, reaching out to patients, all of those resources.
So let me pick up on what you just said, right? Mm-hmm. So think about a health plan now that is in the business of well-being, is in the business of helping populations live longer, healthier lives. That's the value. That's what it gets paid to do, and it is in a competitive space because the plan next door or down the street is competing to demonstrate its capabilities. The minute that happens, the value becomes the patient. The patient becomes the object of value, and I think it's just transformative. I think it just means that we're now competing to keep each other healthy. And it doesn't matter what the race of that patient is or sexual orientation or anything. It means when I get up in the morning, I'm in the business of keeping that patient healthy.
And that right there, sir, is the crux of patient-centeredness.
That is the crux. That is patient-centeredness. That is it. You got it.
To summarize, Dr. Puckrein, patient-centeredness is that's the crux. The way to get there is by elevating the value base of humans and in terms of how we all within the healthcare system and amongst its collaborative forces view each other. It's also decreasing financial risk and other things that you've talked about, reimagining the healthcare system and being able to really quantify and present metrics that are meaningful in terms of outcomes, actual outcomes, and making sure that we understand that the quality of healthcare cannot be subpar if we're really for a swath of the population, if we're talking about driving toward equity.
Yeah, I think a way to articulate it is a is talk about patient-centered or talk about a consumer-oriented healthcare system where the tending to the needs of the consumer in the healthcare system becomes a priority. Right now, our healthcare system is so oriented around managing financial risk that it creates the frustration for your young physician who comes in eager to practice medicine, and the people in the C-suite are up there saying, no, really what I need you to do is to get into the practice of helping us manage financial risk. And that disorientation, if you will, is what leads to that kind of frustration.
That's right. So we want to make sure that people stay inspired, and one way to do that is to get your weekly dose of NMQF webinar conversation, and every Friday. And NMQF wants to hear from you all in terms of what you want to continuously hear. So this right here that's popped up on your screen, it's a poll. You can just take a couple moments, attendees, and just let NMQF know what topics do you want to explore in future conversations. Clinical trials, vaccines, cancer stage shifting initiatives, the Congressional Black Caucus Health Brain Trust and its partners. I'm hearing from them. And I'll include in there the KPAC with respect to Asian Pacific Islanders, and CHC with respect to Hispanic health and such like that, the health of the Latinx community, brain health policy overall, communication strategies or social media outreach. If you're newer to the NMQF family, you may not yet know that NMQF has its own health news outlet and platform for your health news that comes out consistently. And then also artificial intelligence or augmented intelligence technology and its role in healthcare. All right, so you can choose as many as you want, but make sure that you please press that submit button before you sign off on this call. Let's stay here for a couple more seconds.
So you know me, I always enjoy these conversations with you. It's always a good thing.
Oh yes, sir.
Yeah.
It truly is. It's my pleasure.
Yeah, I learned a lot. I think I just think we're in this really interesting place, and we should be expansive in our thinking. We shouldn't be shy or uncomfortable. The beauty of democracy is that you can have a lot of ideas. Some will get to the top, and some won't. But you ought not to feel uncomfortable raising them and talking about them, and because it's crowdsourcing, right? Is the way to go. I think it's the great benefit. Yeah.
That's exactly right, sir.
Yeah.
You're winning. Any other final words from you, Dr. Puckrein, before we go ahead and close out for today?
No, I think I'm excited for all of the work that's going on, and the collaborations and the partnerships, and we love to partner with folks and learn from them. So this has been extraordinary, and everybody should know me as raising a football player over there. I think
he's huge.
The boy is unbelievably used.
He is. He's standing up now, and he's already above my knee. And you just got Earthside 7 months ago, sir. All right. So before we close out, let me turn it over to Keiko, who's going to show us the results of the poll. So most of you, it looks like for sure, health policy, clinical trials related conversations, health brain trust, pretty much everything is apparently going to be trending. So
look forward to it.
That's it. Me too. I look forward to coming back and doing this with you again very soon.
All right. Thanks, Mia.
Appreciate you. Have a great one, everybody. Thanks for attending.